Thank you so much, Julie. And thank you to all of you for joining today. Um, Here are my disclosures. So I wanted to just start by framing this topic and this title, this endemic of hepatitis C and opioid use disorder. So as Julie mentioned, I'm an internist by training. And during my residency, more than 10 years ago at this point, general internists really didn't manage hepatitis C. The treatment was complex, it had numerous adverse effects, and it really only worked about half the time. But in 2013, I had the great honor to work at the NIH, where the first clinical trials on direct-acting antivirals for the treatment of hepatitis C were being conducted. And I watched as patients in as little as 6 weeks were cured in front of my eyes. And that lightning rod in scientific advancement really made me a believer. I thought, okay, great, we can solve this epidemic. Hep C will be totally eradicated. But as you can tell, I still have 45 minutes left to go, so that didn't happen. And instead, what we discovered was that in many cases, in particular for our most vulnerable patients, hepatitis C is really the first layer of the onion. And it's a disease that serves as a symptom for another disease of opioid use disorder. And so a syndemic is really the perfect word to describe the interrelatedness of these two conditions, not only in cause, but in trajectory as well as the outcome. You really can't separate one from the other, and the two make each other worse. Now, this audience today is very familiar with opioid use disorder, so in today's presentation, I'm going to speak mainly about hepatitis C, but I really hope I've made the case and will continue in this presentation that you should frame these topics in your mind as a syndemic. So just broadly, I'm going to discuss the current state of hepatitis C, including pathophysiology and epidemiology. And second, review the diagnosis, treatment, and monitoring in Hep C treatment, and briefly touch on the data on hepatitis C treatment in special populations, including those with opioid use disorder. And finally, I'll discuss some strategies targeting gaps in the care continuum for hepatitis C, again with a focus on individuals with opioid use disorder. So let's begin with everyone's favorite topic, viruses. We've talked enough about viruses for the last year, but hepatitis C is a positive single-stranded RNA virus. It's in the same family as Zika or West Nile, and it has, unfortunately, only one host, and that's us as humans. So specifically, hepatitis C targets the liver's hepatocytes or liver cells, and it uses the body's own building blocks to dynamically replicate at the rate of trillions of virions a day. And unfortunately, what that means is that Hep C is about 10 times more infectious than HIV through blood exposure. Furthermore, due to these virologic features, Hep C has high survival outside of the host or human, and it's been detected on drug use paraphernalia for more than a month after initial use. Unfortunately, hepatitis C also requires temperatures of at least 144 degrees sustained for more than 1.5 minutes in order to be eliminated. And for these reasons is highly transmissible through needles and syringes. Finally, another viral feature is that hepatitis C has multiple subtypes or genotypes, which I like to think of as cousins. You're all part of the same family, but a little different. And genotypes differ in geographic distribution, as evidenced by this map here, and in the past really governed how we treated and what treatment response was like, although as we'll discuss, that's changing. And you can see in the map that genotype 1, listed in red, is the predominant genotype here in the United States, while in India, genotype 3 in green is the predominant genotype. So due to all these viral features just reviewed, the largest risk factor for Hep C acquisition, both globally but in the United States in particular, is injection drug use. Sexual transmission remains controversial due to variability in sexual practices, with several studies indicating a less than 1% transmission risk among heterosexual populations, but larger in MSM populations. Worldwide, Hep C is common and affects more than 70 million people, with an incidence of nearly 2 million cases worldwide. And this map from the World Health Organization demonstrates through color density that this prevalence is not equal, and you see disproportionate rates across Europe, the Middle East, and Asia. In the US, nearly 1% of the population has hepatitis C, and like the previous map, it's not equal around our country, as indicated by color density. Yet, in the last 10 years, there's really been a sharp increase, as indicated by this map, in the rates of acute hepatitis C, with nearly 3,000 reported acute hepatitis C in 2016. So we have a serious chronic disease that's on the rise. And the title of this talk sort of gives it away, but for those of you who joined late, this data from California demonstrates visually what we know to be true. So you can see in this age map of newly reported Hep C cases from 2007, you have a nice cluster around what we call the baby boomers, individuals born between 1945 and 1965. And those were individuals who engaged in injection drug use perhaps decades ago. But what we see now is this shift to a bimodal distribution of hepatitis C infection, where you have, yes, persisting your baby boomer population, but a smaller bump in people who inject drugs aged 20 to 40 with newly acquired hepatitis C. So in our current era, epidemic of opioid use disorder has become the primary driver of rising Hep C rates, and the prevalence in the people who inject drugs population is estimated to be greater than 70%. And we can see this play out even on our own regional level. So while Baltimore leads in the number of cases of Hep C reported in Maryland, when we adjust for population, we see high rates in counties like Washington, Kent, Cecil, and Somerset, which are all predominantly rural populations that have experienced an explosion of opioid use disorder and unfortunately overdose death. So rates of acute Hep C in this younger age group of 20 to 40-year-olds has risen so dramatically, it's prompted last year the U.S. Preventative Services Task Force to change its screening guidance. So now all adults aged 18 and over should be screened for hepatitis C. Finally, what happens after you have hepatitis C? So after exposure, approximately 20%, the lucky 20% of individuals, are able to spontaneously clear the virus with no active infection. But unfortunately, the majority of people, 80%, go on to have chronic infection. And of those chronically infected, over several decades, constant replication and fibrosis within the liver will progress. And that will lead to advanced liver fibrosis and cirrhosis, otherwise known as scarring in the liver. And of those who develop cirrhosis, about 5% will experience an outcome, including end-stage liver disease, hepatocellular carcinoma, or unfortunately death. And while 2 to 7% may seem very little, multiply that in the global population of millions of individuals with hepatitis C, and you see why until very recently, hepatitis C was the primary driver of liver transplantation in the United States. So I'll just take a pause and see if we have any questions in the chat box before moving to diagnosis and treatment. Okay. Looks like I've been crystal clear, but I probably should have said that. If anyone has questions, I know that you can't unmute yourself, but feel free to put them in the chat and I'll try to pause. So let's move on to diagnosis, treatment, and monitoring. So diagnosis is actually really has become very simple. So the initial test for Hep C is the antibody test, which evaluates exposure. An RNA test measures the amount of detectable virus and is the confirmatory test for actually having Hep C. So fortunately, this process has largely been automated through reflex antibody to RNA, even to genotype testing. But it's important to know that in individuals, in those the lucky 20% of individuals who've naturally cleared Hep C, or in individuals who are treated and cured of hepatitis C, their antibody will remain positive, although their RNA should be negative. In individuals with detectable RNA, these are the ones who need to be linked for further care and treatment. So, as I stated initially, hepatitis C treatment has undergone this amazing and rapid evolution from interferon-based regimens with really low rates of sustained virologic response, as indicated on the left side of this diagram, to now combination direct acting antivirals or DAAs with cure rates of over 90%. So by national consensus guidelines for the treatment of hepatitis C, treatment is recommended for everyone who has a chronic infection. And I will just say that for any individuals, on this call who are really looking for an in-depth understanding of guidance around Hep C treatment, I'll refer you to the hcvguidelines.org, which is a collaboration between the Infectious Disease Society of America and the American Association for the Study of Liver Diseases. And it's really our predominant clinical guidance for the treatment of Hep C. As you can see, this treatment has the highest rating possible in terms of evidence, and for several reasons. There are multiple reasons why patients along the spectrum of liver fibrosis should be treated for Hep C, and these include reduced end-stage complications, as well as, for the general population, reduced transmission, and for the individual, reduced progression of disease. And critically, treatment saves lives with a 70% reduction in mortality after cure of hepatitis C. So the direct-acting antivirals use some of the strategy of antiretroviral therapy in HIV, in which multiple drugs are utilized to target different aspects of the Hep C life cycle, which work in tandem to eliminate viral replication. Now, the good news is, because of specific features of hepatitis C can be cured, unlike HIV or hepatitis B. And we have a variety of highly efficacious treatments. So here listed are recommended regimens for initial treatment of hepatitis C, which include 4 options that vary from 1 to 3 pills a day, 8 to 12 weeks of duration, all with cure rates above 90% across the spectrum of genotypes. And you can see here, the 2 options listed at the bottom are what we call pan-genotypic, which mean that they have demonstrated efficacy in elimination across the different types of genotypes. So when you prepare someone for Hep C treatment, there are essentially 3 broad categories of assessment, and these include some measure of fibrosis or scarring of the liver, some type of medication reconciliation for potential drug-drug interactions, and some lab work. And the lab work really needs to include an assessment of synthetic, renal, liver function, and then testing for HIV, hepatitis B, and pregnancy. It's important to return to the fibrosis component, that can be evaluated with anything from simple lab tests or online calculators to something a little more in-depth, such as the use of transient elastography. By and large, liver biopsies for the reason of establishing fibrosis is no longer recommended. So, the great news is that we've reached the era of quote unquote simplified treatment, and that's verbiage from the guidelines that I had mentioned. The vast majority of patients with Hep C can be treated utilizing this approach. And specifically, the simplified treatment approach should be used in treatment naive, non-cirrhotic patients. And non-cirrhotic simply means less than a stage liver on fibrosis, stage 4 on liver fibrosis assessment. So in the categories listed in the purple, next to the purple arrow, these are groups that really should not be utilizing simplified treatment. But treatment is not complicated in those individuals either. The good news is that the vast majority of people presenting to your office, including individuals with opioid use disorder, will be in the simplified treatment category. So here are the first-line agents according to the simplified treatment protocol. On the left, we see a picture of glecaprevir pibrentasvir, or Mavorit, otherwise known as GP. And you can see what is pictured there is the tablets recommended for 1 day. That's 1 day's worth of dose. And on the right, you can see sofosbuvir velpatasvir, or Epclusa, which is what's depicted there is a pill bottle of 1 month duration. So there are several factors to consider when deciding on an initial treatment regimen in simplified treatment. GP is an 8-week duration, but 3 pills daily, and the pills should be taken with food. And as depicted in the last photograph, each day's worth comes in a tiny, box, which when stacked all together is a pretty large box that represents 1 month's supply. On the other hand, sofosbuvir velpatasvir is a 12-week duration. It's a single pill. You can take it with or without food, and it comes in a bottle. So the most important primary deciding factor in treatment is insurance. And we're lucky in Maryland that both first-line agents are covered by Maryland Medicaid, and therefore some nuance and patient preference can be applied in your decision-making. So some things that I consider during treatment decisions are patients' priorities in terms of the length of treatment versus the pill burden, their ability to store medications, such as their ability to have a box versus a bottle, and their regular accessibility to food. So on-treatment monitoring is amazingly simple in the simplified treatment protocol. Really, you just need to check in with your patient in some way, shape, or form. It can be telemedicine, in person, over the phone. You should ask about adherence. You should ask about common adverse events or side effects, which include headache, upset stomach, and feeling tired, but occur in actually less than 10% of patients. And if everything is going okay, no labs are needed during the on-treatment phase. After 3 months after the patient takes their last pill, whether it's 8 weeks or 12 weeks, 3 months after that date, there should be an assessment of sustained virologic response, aka cure. And you assess this simply with HCV viral load. And again, that's testing the presence of RNA, the presence of the actual virus. If the result is that there's a positive RNA, unfortunately, the patient has not been cured and they have either relapse or reinfection. In the case of no detectable RNA, you have achieved your patient has achieved sustained virologic response or cure. Recent data presented at the Conference on Opportunistic Infection supports the high success of Hep C treatment in a minimal monitored approach. So in this investigation, there were no pre-treatment labs, and all 3 months of medication were dispensed to the patient at one time. So they came in with the diagnosis of Hep C, got 3 bottles of medication, were contacted at weeks 4 and 22 over the phone or by text message, and then were brought in again at week 24 to assess for sustained virologic response. And in this global study of nearly 400 patients, there were cure rates of 95%, really reinforcing the safety, simplicity, and efficacy of Hep C treatment. So all the messages are consistent: safe, efficacious, and straightforward for both providers and patients. So finally, what happens after cure? So say someone achieves cure. What else do you as a provider need to keep in mind? So for individuals who are low risk, meaning people who have less than a stage 3 fibrosis and really no ongoing risks for reinfection, you don't have to do anything. This is the only time that I, as an internist, have broken up with my patients and I've said, it was really nice knowing you. I hope I never see you again. Of course, in my patients with opioid use disorder, as a chronic disease, we continue to see those individuals. And for individuals with advanced fibrosis, which is stage 3 or 4 fibrosis, you do need to undergo some appropriate cancer screenings, including screenings for hepatocellular carcinoma, and for individuals with cirrhosis, screening for varicose disease, even again, if they are cured. And finally, importantly, for high-risk groups, such as people who inject drugs, men who have sex with men, or HIV positive individuals, the recommendation is to obtain yearly retesting for hepatitis C because of the risks of reinfection. So I do see a question in the chat. What is the extent of blood work needed? For IV drug users, getting blood samples can be difficult at times. Absolutely. Thank you for this question. You know, the recommended lab work before initiation of treatment is very simple. It includes, of course, assessment of hep C viral load, renal function, liver function, and that's pretty much it. Right now, simplified treatment, there is no on-treatment labs that are really recommended if everything is going well and your patient is not experiencing adverse events. So what happens if a patient is not cured? So the first thing is you really need to figure out what happened to them. In the vast majority of patients, it will be relapse or treatment failure. So they'll have the detectable viral load, but it's the same genotype that they started with. It's probably the same virus. It just was unable to be suppressed. So real true treatment failure or relapse is exceedingly uncommon. It's estimated to be less than 10%. So why do people fail? The same reason that so many diseases are hard to treat, because of adherence to medications, life circumstances that get in the way of really achieving high levels of adherence. The good news is that there appear to be high barriers, meaning patients don't always have to be 100% perfect to obtain a cure. I never tell my patients that, but the good news is persistent treatment until you know that they fail. If they've failed, don't fret. There are other alternative regimens. You can't do simplified treatment again, but there are alternative regimens that can be used. In contrast, reinfection, which I always suspect in individuals who have ongoing risk factors for HCV acquisition, my people who inject drugs population, can sometimes be identified by a genotype switch. So I may be treating someone who started out with a genotype 1, and then I get their viral load at the SVR assessment time point, and they now have a genotype 3. Well, that's a different virus. The most likely scenario is that they acquired a new disease. The only good point in that is that that disease, that genotype 3 hep C, can be treated as if it was an initial infection because the genotype 1 is gone, but this new virus can be treated as a new infection. If your patient does not achieve cure, don't worry. Viral relapse is going to occur and reinfection will occur. Particularly for viral relapse, one of the best ways that I try to assess with my patients is to just say, hey, what happened? And the vast majority of my patients who've had viral relapse had life instability or challenges that really got in the way of maintaining their adherence. I've also had patients with drug-drug interactions because of spontaneous new medications that they decided to take. Reinfection will occur and is a sign that you're actually in the right population. We don't only want to be treating people for hep C who acquired it in 1965. We want to be treating people who have risk factors for ongoing transmission. That's the only way that will actually eradicate hep C. And the truth is, harm reduction is really the key to preventing reinfection because someone with opioid use disorder could be injecting 6 times a day, but if they had access to unused drug use paraphernalia, they would not acquire Hep C. So harm reduction is really foundational in our patients who have high risk of reinfection. So I did want to mention one word on treatment in special populations. And this is referred to in the HCV guidance as individuals with HIV and people who inject drugs or people with opioid use disorder. I put special in quotation marks because the truth is Hep C treatments work in these populations too. So we can see this is multiple different studies which utilized different direct acting antiviral regimens in patients with HIV Hep C co-infection and compared to people with HCV infection alone, really equivalent cure rates across the board. So HIV requires some additional thought because of antiretroviral therapy, but in terms of rates of cure, equivalent to patients with just Hep C. What about patients with opioid use disorder? So when I started doing hepatitis C treatment in 2013, as direct acting antivirals got approved by insurance companies, there were a lot of restrictions in place for around people who used drugs. So in 2015, in the state of Maryland, if you were a patient who had opioid use disorder, you had to have sobriety or prove that you did not use drugs for 6 months before insurance would approve your hepatitis C treatment. What many studies over time have demonstrated is that such restrictions are not evidence-based, and people with opioid use disorder across the spectrum, from individuals who are in recovery on medication for opioid use disorder to the individuals not on MOUD with active injection drug use, across that whole spectrum, they can all be cured of hepatitis C. So you can see here in individuals with and without medication for opioid use disorder, equivalent cure rates. And another additional study called the C-EDGE COSAR study said, okay, well, let's talk about people who are on medication for opioid use disorder, but who continue to use drugs. And you can see that the majority of people who use drugs with or without a negative urine drug screen achieved cure. And then the Simplify study took this one step further and really narrowed down to the population of people who injected opioids, our most high-risk population. Some who were on medication for opioid use disorder and some who were not. And you can see here equivalent rates of cure across the board. So the bottom line is that treatment in special populations is not very different. There are some additional things that you need to consider, but the efficacy really has been supported by the data. So there really should be no hesitations when it comes to the treatment of Hep C. So I think I just saw Julie says we've gotten a couple of questions. So I can only see one, Julie. So maybe you can read them out loud for me?
Yeah, absolutely. I received a couple of questions in the chat, just sent to me. One of them is active ETOH use a contraindication?
Yes, so active alcohol use is not a contraindication to hepatitis C treatment, but in my patients with alcohol use disorder, I always want to know it, and it's really a great time for intervention and counseling. Because of course, we know that the other major reason people develop cirrhosis in the United States is through alcohol use disorder and steatohepatitis. And so it has actually helped me with a lot of my patients have the conversation about their alcohol use and strategies to reduce their alcohol use. There's no contraindication because again, even in individuals with stage 4 or cirrhosis of the liver, whether it be from hepatitis C or alcohol use disorder, there are still benefits to treatment.
Great, thank you. One more question that we have is that do you need to treat the partners of a patient as well?
Great question. Great question. I always use it as an opportunity to discuss. Patients often have great insight about where they got their hepatitis C from. It's not always a conversation we have to have. Um, as I had mentioned, transmission through heterosexual sex, there's not a lot of great research to support high transmission. But in any form of sex where you have mucosal tearing or blood exchange, that is where hepatitis C really has a higher viral burden. So particularly in our MSM population or in sex that involves the use of toys or anything where there can be blood or mucosal tearing, there are much higher, it's a much higher risk calculation. So in my patients, who have a regular partner, I always will try to use that as an opportunity to say, out of an abundance of caution, let's get your partner in, let's get them tested, and let's treat you guys together. So it's something that I really try to use an opportunity to do.
Great. And then I also saw just one last question in the Q&A. Dr. Shah had said that they've received denials when they're testing the patient for the first time. Some MCOs say they have to prove chronic hep C by repeat testing in 6 months, which delays treatment. Are there any guidelines regarding documenting chronic hep C in less than 6 months?
Yeah, so I can tell you that I just was recently part of a group of individuals who wrote a letter to Maryland Medicaid on behalf of the Hepatitis C Coalition in Maryland, um, specifically regarding this hepatitis C chronicity, establishment of chronicity. I think having two separate HCV RNAs greater than 6 months apart, it really does not make sense in establishing chronicity. There are multiple ways to establish chronicity. One is by patient history. It doesn't happen all the time, but patients can sometimes tell you about the jaundice that they experienced when they were first infected by hepatitis C. It can be through a history of risk factors, such as people who have injected drugs since the 1980s. It's very unlikely that they acquired hepatitis C in the last 6 months, when all of the research demonstrates the highest risk of acquisition is really in your first year of injecting. And then, of course, the most egregious evidence of a chronicity is in liver fibrosis, because hepatitis C is a slow moving disease and it really won't develop scarring on the liver except over decades of time. And so really history of symptoms, history of exposure, and lab work, including liver inflammation, synthetic dysfunction, or liver fibrosis, should be enough to establish chronicity. And that's the argument that we are trying to make to Maryland Medicaid. So the fight is not over, but yes, right now, I think that's a huge burden in that's very disruptive to care, particularly in COVID-19. Making people come back multiple times for a disease they've had for 20 years is very disruptive. Any other questions, Julie?
I do see one that was just added to the Q&A section. They are wondering, is there any information surrounding patients who continue their illicit use and end up recontracting HCV? Will they be denied for getting treated again? Their main concern is that with substance dependence being largely chronic and relapsing, that there's a higher likelihood for recontraction. At what point do insurance companies just flat out say no?
Yeah, this is a very real challenge. So this is exactly the patient population that I work with is patients with ongoing injection drug use who have hepatitis C. I have found lots of creative ways to get hepatitis C treatment approved, either through the argument of benefit to the individual patient or through a well-written letter of medical intent, just stating the benefits to public health transmission. Unfortunately, it's inconsistent across the different MCOs. So we have, of course, fee-for-service Maryland Medicaid that should be sort of governing and have a consistent answer across the MCOs. But all of us who do this care know that that's not the case. So what I've found is that persistence is really the key, and that's easier for me to say than it could be for others who have a really busy primary care practice. Absolutely. But I think retreatment is something that I pursue aggressively because number one, of the benefit to the individual patient, but also decreasing the viral burden in the injecting drugs community is so critical to actually stopping ongoing transmission. So every opportunity I get, I will retreat someone as quickly as possible. So hopefully that answers your question.
Thank you, Dr. Katakizzi, and thank you everyone for such great questions.
Yeah, this is great. Okay, I can say at least 5 people were paying attention, so that's awesome. So I think a couple of the questions really alluded to what I'm going into now, which are some of the challenges and strategies used to improve Hep C care. So what I've really left out of this talk, because I could talk about it for days and it would take up the whole hour, is actually the challenges we face in providing Hep C care once we've gotten patients in the door, once they're ready to be treated. And these mostly have to do with policies, like some of the things we've mentioned, insurance-based restrictions, on diagnosing chronicity, on denials, not because of their substance use, but because of adherence concerns, etc. So maybe we'll try to do a part 2 at some point, later on in the year. But what I want to talk about now are really some of the challenges just about actually getting marginalized patients in the door, and how we can best serve our really vulnerable patient populations with an emphasis on those with concomitant opioid use disorder. So, we know that hepatitis C treatment works. I talked about the MinMon study. You basically throw 3 bottles at somebody and they can have a cure of rates of over 95% 6 months later. But despite this amazing technology, in this review article from 2014, so a bit dated, but even updated studies have demonstrated there's still not enough medication that's actually reaching the hands of the population that need it. And there is a huge gap in the number of people who are actually infected and who are diagnosed and aware that they have the illness. And so this continuum, the largest gap is in that first step, those who are diagnosed and aware. And in large part, this comprises our most marginalized high-risk patients who don't have a regular primary care doctor and who are not coming for regular care and are unaware of their illness. And these are the same patients that are really the progenitors of the ongoing hepatitis C epidemic, and these are our patients with opioid use disorder. So, I think there are a lot of barriers to hepatitis C treatment. We talked about some of them in the question, and I would say that the structural barriers are huge. That could be its own talk. But it's also important to acknowledge that there are provider and patient barriers. And some of the provider barriers include things like reticence to treat people who inject drugs because of that concern for reinfection. And on the patient side of things, in particular our patients with opioid use disorder, competing health and social priorities. When you're worried every day of your life about a fentanyl dose, the disease of hepatitis C, especially in someone without fibrosis, may or may not seem very important. I want to underscore the fact that we as providers really contribute as a barrier to this. So in this survey that was done of hepatitis C providers, concerns about adherence and reinfection risk were among the highest reasons to deny people hepatitis C treatment, despite the fact that we have great evidence that I presented in special populations that people who use drugs can achieve excellent rates of sustained virologic response and sufficient adherence. There is the concern for reinfection, but the reinfection potential in an individual can be highly mitigated through the use of harm reduction. So we have strategies and we have evidence, but unfortunately, that is not always able to overcome stigma and discrimination. So here are what I think are that all providers and anyone who cares for patients with Hep C should really try to use as foundational principles in the provision of care. And these are, first, to incorporate a harm reduction framework in their Hep C care. Second, to try and co-locate services as much as possible. And 3, to decentralize services. And so I'll just give you a couple examples of what I mean by each of these principles. So incorporating a harm reduction framework means addressing our own internal stigma and discrimination and fighting external forms of stigma and discrimination, such as discriminatory insurance policies. So, the stigma and discrimination against opioid use disorder is so huge. There's a disregard for the disease model of addiction, which really understands the biological concept of addiction rather than a moral failing. There's so many misconceptions about medication for opioid use disorder. And of course, the reality is our patients face everyday risk of arrest and incarceration due to the criminalization of substance use. So while these are not always factors in hepatitis C care, for our patients with opioid use disorder, it's something that we really have to think about all the time and is why a harm reduction framework is so important. So one of the principles of harm reduction is to meet people where they are. And so when we think about treatment, it really doesn't need to be in the setting of a doctor's office. For the last 5 years, I've practiced out of a methadone opioid treatment program on the campus of University of Maryland, where we built an integrated Hep C clinic. And I can tell you, the treatment that we have there is very highly successful because we made it a one-stop shop for patients with opioid use disorder to be able to get treated. And of course, we know that our patients with opioid use disorder are disproportionately affected by homelessness. And so being able to do testing initiatives and treatment initiatives linking patients where they already are is so huge. Of course, another principle of the harm reduction framework is to understand as much as we can about the patient and to get as much information as we can. So getting many phone numbers in case one of their cell phones dies out, understand through our community health workers where they're hanging out, where their sleeping spots are, and not in our older population, but in our younger population, if they have access to social media. So all of these are ways that we can continue to keep in contact with our patients and maybe not require them to come into the office. And one principle of co-location of services is strategies that not only provide care, but also provide ongoing linkage and retention. So not only are you treating someone for hepatitis C, but maybe not yourself, but someone in your office. Can you provide transportation, reminders? Can you help people get in IDs? I can tell you that's such a huge issue, as you all know, in some of our more marginalized patients with opioid use disorder, and especially those with homelessness. If you can provide something for the patient that's more on their immediate list of needs, they're more willing to then come in for the medical treatment that we really want them to be there for. Testing of co-location of services, co-location services of testing is also so critical. So being able to test, but perhaps utilizing a peer counselor, someone with links of drugs who's providing testing. And again, in convenient locations that make sense to the patient. Co-location of treatment services is another important principle that I think is really important as we frame this idea of the syndemic of Hep C and opioid use disorder. So my colleague in the Division of Infectious Disease, Dr. Alana Rosenthal, led a study called the Anchor Study, in which we had a clinic in a syringe service program in Washington, D.C., and we offered patients who wanted to be treated for hepatitis C 12 weeks of sofosbuvir velpatasvir. And we treated them and monitored them for reinfection, but also offered them buprenorphine and PrEP, which was optional. And again, this was not an opioid use disorder treatment seeking population. They were coming for syringe exchange and Hep C treatment. What we found was that 82% of individuals were cured. 11 had virologic failure, about 4% were lost to follow-up, and we did have 3% of patients who died. But what we found was that medication for opioid use disorder had a distinct effect, again, in a non-treatment seeking population. So out of 100 people who started on Hep C treatment, these are all individuals with active injection drug use. 67 were not on any medication for opioid use disorder at baseline. 80% of them started on medication and 70% were retrained at the 6-month time point. And this impacted in this really high risk group of individuals, their ability to obtain cure. So finally, the last principle in overcoming barriers in Hep C treatment is this concept of decentralizing treatment. So what does that mean? It really is the principle of the way that we previously envisioned hepatitis C care, which is in an academic medical center specialist office who is either a gastroenterologist or infectious disease provider. That's really done. It's over. As I showed you in the MinMon study, there's very little ongoing treatment monitoring that needs to be conducted. And in the era of direct acting antivirals, all the various provider types that you see here in all the various settings that are listed here have demonstrated success in studies of direct acting antiviral treatment. So decentralization is this concept of getting Hep C treatment out of these silos of care, getting them where people are, getting them more accessible through task shifting. So I was very lucky to lead a study really centered on this idea of decentralizing treatment. This was back in 2016, called the ASCEND study, in which we, in a federally qualified health center settings in Washington, D.C., treated treated hepatitis C in an urban population utilizing 3 different provider types listed here below: nurse practitioners, primary care physicians, and specialist doctors. And you can see across the board, high rates of cure of hepatitis C, equivalent across the 3 provider types, including patients with cirrhosis listed in green. And this was really only after a targeted 3-hour training protocol. And that was back in 2015 when DAA treatments were even more complicated than they are now. So in conclusion, a couple of key points that I hope you can take home with. Hepatitis C incidence is rising due to the epidemic of opioid use disorder, but all adults aged 18 and older should be screened for hepatitis C. Initial treatment of Hep C in non-cirrhotic patients is very straightforward, and primary care providers can and should treat hepatitis C, inclusive of our marginalized populations with high risk for reacquisition and reinfection. Improving care for patients with opioid use disorder and Hep C really requires a harm reduction framework, and through the principles of co-location and decentralization can make it as easy as possible for patients to access treatment. And this syndemic framework of care, in utilizing these principles, improves not just the hepatitis C and the risk of cure, but also will improve potentially the patient's opioid use disorder, their engagement in care, and potentially other social factors. So with that, I want to thank you all for your attention. My contact information is there. I will also put it in the chat box, and I'm happy to open up the floor to any questions.
Thank you so much, Dr. Catacuzzi. I do have one question from the chat. Someone is wondering, does the Hep C medications have a street value?
Great question. Yeah. So from what I understand, no. but that has not stopped my patient's medication from getting stolen pretty frequently. Insurance, it's kind of like buprenorphine. It's the most helpful thing to replace a stolen hepatitis C batch is to have a police report indicating that the item was stolen. I've had a lot of success for patients who have a police report that we can send into the insurance company to sort of prove. But I've even gotten around it by just writing a medical letter again as a physician stating that the patient was, either robbed or left it on, had it stolen or things like that. So again, I think while in general there's not at least a well-known street value in the same way that kind of anybody will steal anything. I've definitely experienced that with my patients.
Thank you.
Okay, any other questions on your end, Julie? I don't see anything else in the chat.
Nope, I haven't received any more in the chat either. And just a reminder to everyone who is on, so you will receive an evaluation once the webinar is finished, and you need to complete the evaluation in order to receive CME credit. So that should pop up after the webinar closes, and if not, we will be emailing you it. But if you have any questions, you can always feel free to reach out to us, and I will put our email in the chat. And I'll be staying on for just a couple more minutes just to wrap things up. But so if anyone does have any questions, definitely feel free to let us know. But if not, thank you all for joining. And thank you so much, Dr. Catacuzzi, for such a great presentation.
Thank you guys so much. I really appreciate it. And I did just want to put it out there. If there are any providers who are having some challenges in terms of getting approvals or having some, frequent issues with insurance, please contact me, not only for your patients, I have some tricks, but also because as kind of a group of providers, we really want to be advocating for our patients in the best manner possible. And we really are, through the Hep C Coalition, trying to aggregate that kind of data. So please feel free to reach out to me. This is obviously, I'm really passionate about it, and would love to help any of you guys who are kind of struggling with any of these issues. Thank you guys so much. I'll just stay on for the, until 2 o'clock if anybody has any other questions.
I just saw something was added. Someone's asking if we'll be sending this recording. Yep, so we will be sending you the recording and the slides, hopefully by next week. And then I just saw another question in the chat too. Someone is wondering if there will ever be a vaccine for Hep C.
Great question. There's a lot of research that's going on around a vaccine for hepatitis C, so I think that it will come. Nothing yet that I've heard of, and I really try to keep on top of the latest research. But if anybody else knows anything, I'd love to hear it. But nothing that I understand right now is close to going into, in human trials.
Thank you. One more question we got is there any scenario where PEG interferon is deemed to be preferred or useful over the tablets?
Pretty much never at this point. There are some specific ways to utilize case treatment in individuals who failed specific regimens. I think the other use of interferon-based therapies are in areas that don't have access to direct-acting antivirals, but those are really becoming less and less globally. So for the most part, we really don't use PEG interferon anymore, in our treatment. Thank goodness.
see. There's one more that was just added. They are asking, are there any studies looking at rapid start for Hep C? For example, point of care testing and starting same day like we do for HIV?
Yeah, awesome question. So I think the big limitation has been that rapid testing component, just because, you know, theoretically, you don't want to start medications on somebody who has a positive antibody. So right now we have rapid testing that in 20 minutes can tell you if somebody's antibody is positive, but we don't have FDA approved RNA testing. So theoretically, if you went off of just the finger stick testing for antibodies, you would overtreat by 20%. Which we didn't talk about this, but the hepatitis C medications are still extremely expensive. So that doesn't make sense from a public health strategy. But there's tons of research around technologies that are developing, and some are approved in Australia and other parts of the world for rapid diagnosis of finger stick testing. So I think that's absolutely the wave of the future. It marries so well with a harm reduction approach. You just go out to your places where you know the people who inject drugs community are there. You check them, using a finger stick test or maybe one day an oral swab, and be able to establish the diagnosis and chronicity of Hep C and be able to offer them on the spot testing, the on the spot linkage to treatment. So I really see that as, the backpack model of Hep C treatment of the future. Unfortunately, insurance prior authorization gets in the way of that. So the other big factor, of course, is the cost of hepatitis C medications, which have come down by more than 50% in the last, 5 years, depending on, the specific state. But I think that the prior authorization process really, we can't write a prescription for Hep C. It has to be approved by insurance. So until we are at a time when we eliminate the prior authorization process, that model would not be possible. New York State recently eliminated in the last few months the prior authorization process for hepatitis C. So we are going to get there in Maryland too.
Great. I don't see any more questions in the chat, but I'll be hanging on just to wrap up and save any of the information. So if anyone has any questions, I'm happy to relay them to Dr. And thank you all for joining. And thank you again so much, Dr. Catacuzzi, for taking the time to answer all these great questions.
Thank you guys so much. Such intelligent, great questions. Our patients are in good hands.
Absolutely.
Julie, do you need me for anything else?
No, that was it. Yeah.
Okay.
Thank you.
Bye, everyone. Thank you.
Bye-bye. All right. I was just saving all the chat and Q&A questions, but I don't see any more. So I'm going to end the recording. Thanks, everyone. Bye-bye.